appreciate that vaccination is pivotal to our success in controlling the spread of the COVID-19 pandemic. And today, I'm indeed delighted to introduce to you our two panelists. We are going to hear from Dr. Tapati Dutta, who is a social scientist and an inclusion strategist in public health, with over 25 years of blended experience in research, teaching, and service. And she has her widely viewed TEDx talk. Please take off some time after this webinar to view that talk. And she's currently an assistant professor at Fort Lewis College in the USA. Dr. Tapati, you're very welcome to deliver your presentation.
Thank you. Thank you so much. Just a quick question, Dr. Eve, that would you introduce both the presenters before I start?
Okay. Okay.
Thank you.
I'll briefly introduce our second presenter, and you'll be hearing from him after Dr. Tapati. And our second presenter is Dr. Driwali Alfred, who is the Assistant Commissioner of Health Services in charge of vaccines and immunization in Uganda. He has a lot of experience in vaccination and immunization, both within Uganda and across Africa. And he has a lot of expertise in health system strengthening and effective service delivery, most especially in primary health care. So you'll have an opportunity to hear from Alfred as well. And I encourage you to put your questions in the Q&A box if you have some questions already. And also all the presenters will have an opportunity to respond to the questions that you put in the Q&A after their presentations. So without further ado, I'll kindly request Dr. Tapati to start us off with her presentation. And we can keep saying hi to each other in the chat box. Thank you.
Thank you so much for that lovely introduction. This is early in the morning out here, and I'm all geared up to talk about one of the most pertinent, I think, discussion which the whole world is having today. And vaccines and vaccination is almost becoming a social norm rather than an individual decision. Thank you, everybody who from maybe different parts of the world have participated. Absolute thank you. So my presentation would be basically two of my research studies which I had done, one in India, another in Kenya. I'm trying to just showcase that some of the strategies or some of the community-facing mechanisms which actually work towards increase of vaccination rates or vaccine uptake. And not only that, it actually helps in building trust between science and common person, between vaccine decision makers and common people. So that is how I did two technical researches. I would try my best, considering that the audience is very diverse, I would try my best to present in a very layman language while also presenting, or in parallel, also presenting some of the rigor of the research which was undertaken. So this is, I think, one of the agenda of this study, of the presentation, of my presentation, is that how research can also build towards evidence for advocacy for vaccination uptake. So I'll just quickly share my screen. Are you able to see the screen? Are you able to see the screen?
Yes, we are seeing it.
Okay.
Thank you.
Okay. So, without doing much ado, Two of my researches, as I mentioned, one is on gender responsive vaccination policies and how it impacted tetanus vaccination, a case study from Kenya. And another is community engagement as an effective strategy and how it might impact vaccination. So the first was a research study done during when I was doing my PhD. And the second was actually my PhD thesis, in which I had interviewed vaccine decision makers at the national level. And I'll present the findings and the critical thoughts around it. As Dr. Eve had mentioned, my education has been around, I began with social work and population studies, did some courses in participatory research, bioethics, and finally, my terminal degree is in public health. So as you see, my research is mostly very translational, which means that whatever I get in theory, I try to use it or I try to recommend such that it can be used for the people or for the people who need it the most. So that is what I mean by translational research. Again, why I did what I did, or why I chose to become a translational or participatory researcher. My formative years after studying social work and population studies has been mostly in the communities, working with very difficult communities, working in very interior locations of South and Southeast Asia, including India, some parts of Eastern and Southern Africa. So I think that was the building or the formative time when I was actually realizing what kind of disparities, health disparities exist, to what degree, to how much of it, because most of these were, again, not just fieldwork experiences, but also lived experiences, living with those people. At another end, you see a very known face out here. That whole experience of building evidence from the communities led me to meeting or working with some of the stalwarts globally who are the stalwarts in different fields of vaccine science, of palliative care. The second woman in the pink sari, whom you see, is Dr. Soumya Swaminathan. She's the chief scientific officer at the WHO Geneva now. The lady we were talking about gender balance, so I'm talking about the ladies first. So the lady in the orange sari is Dr. Suniti Solomon. She passed away recently, but she was the first woman, she was the first doctor who identified the first HIV case in India. Of course, you know Dr. Luerica down in the middle, the picture out there. Judith Lasker, towards the right, the woman in curly hair. She is a woman who has worked a lot on global health volunteering and how volunteering work from the West to the Eastern or the global South countries actually is more harmful than helpful. So people, maybe there is a very misnomered definition of how help and aid and all those things are happening. Up there, the man with beard is Dr. Wayne Koff. He's a vaccine. He heads this organization called Human Vaccines Project. He has been nominated as one of the, I think, 10 most influential people in US's policy making, which included Barack Obama and people like Bill Gates. And so he was one of them. So that is what I'm trying to describe is in our work, we generally cover this whole spectrum from the community to the policymakers. And many times, the inputs, the discussions often inform our own research agenda, our own research ethics also. This is the first paper which I would mention, and these are the publications. It began long back when Gates and WHO had funded a project on how gender impacts immunization or not. And as you know, India being one of the most, and this was a multi-centric study done in different countries. Of course, India being one of the countries where gender empowerment index is not very high. we did it. But the greatest part was I was responsible for the qualitative arm of the study. Very few of these studies either one do qualitative, only qualitative, or do mixed methods. So public health by-in by, some of the formatting are also changing, and public health by-in by are relying on aspects like things like trust, trustworthiness, empathy. And for that, as much as quantitative studies are being done, quantitative research are being done, qualitative studies are also done. But this was, as I am telling you, the far left picture, as you see, it was done in 2010. And some of the findings did show that at a household level, gender discrimination is there in terms of immunization of children. And this is, we are talking about childhood immunization. That stuck into my mind. And long after that, when I was in 2016, 17, I think, I took up this, the KDHS data set, which is the Kenya Demographic and Health Survey. And I looked into the tetanus vaccination uptake among women in Kenya. As all of you might be more knowledgeable than me, I'm not getting into the details of this, but of course, Kenya has recently eliminated maternal and neonatal tetanus. However, the dropout rate is very high. There are many districts where there are high tetanus deaths. There are some kinds of, there was in between, I would say 2013, 14, there were some therapeutic misconceptions. And I see this, or we have seen this across different vaccines and rumors around tetanus that the vaccine is lined with a chemical which will sterilize the girls, which would sterilize the women. And that's how they were very skeptical to get vaccinated. But in parallel or simultaneously, policy, program, and resource investment for tetanus vaccine was continuously happening. And that is probably the reason that the country has eliminated maternal and neonatal tetanus. This was by far, as much as I know, this is the first national level study which is comparing tetanus vaccination among women before and after the Kenya National Policy Guidelines for Immunization. So we took up this policy document and we did a content analysis, which was qualitative study, qualitative method, content analysis of this policy document. What we also did was we took data from Kenya Demographic Health Survey before the policy, which was 2008-9, and after the policy, which was 2014, and analyzed that data. The content analysis, as you might, something which me as a researcher, I stumbled with was, what is the exact language I would take as an indicator or a marker of gender? There were no straightforward words, sentences, phrases, which were markers of gender, or that was not even an outcome indicator for the policy itself. So what we did was we took some keywords like communities and stakeholders, which talked about engagement with the communities. We took phrases like women and girls, women and different, like anywhere where different age groups of women were mentioned, or the words girls were mentioned, and communication. So what kind of communication was happening? Second, what we did was logistic regression of the Kenya Demographic Health Survey, as I mentioned, pre and post 2008-9 and 2014 data set. And the outcome variable was receiving at least one maternal tetanus injection either before or during the most recent pregnancy. Because the WHO recommendation, I think, is at least one or maximum of number of 7 vaccines. Some of the things which we took in the indicators which we took were educational level, place of residence, and religion. And women who had mentioned other and no religion were kind of combined together because they were very few in number. In terms of communication, we took women's exposure to family planning in the newspaper, women's hearing family planning messages on the radio, and sorry for the setting out there, women's hearing of family planning messages or looking at watching family planning messages on the television. So just to give a brief background, Kenya Demographic Health Survey basically has the women's questionnaire based on which the survey is conducted. It also has men's questionnaire and the household questionnaire. So these elements were taken from the women's questionnaire. As you can see very well, that there weren't any of those communication-related indicators to vaccination. So the closest we could find was family planning-related information, which was communicated via the newspaper, television, and radio. So those things were taken. So I think a strong message out here that if vaccination-related communication indicators can be included in the national level surveys like Kenya Demographic Health Survey and the same survey which we have in Uganda, we have in India, we have in almost all the countries, the demographic health surveys which we conduct. On content analysis, as I mentioned, we were looking into words like women and girls, we were looking into communication, and some of the words we found were, it was a gender inclusive language. There were many times mention of different age groups of women, like women and girls, women of menopausal age, women, adolescent, so many words which were mentioned. Focus on specific subpopulation or vulnerable women, like women with O positive blood group, tribal women. Those were words which were there. Addressing vaccine needs using women's lifespan approach, which was very clear because all age group of women were mentioned in the vaccine policy. There is a robust communication strategy and communication plan, and it had very surprisingly and very important, I think, as we are planning for COVID vaccines, that there was interventions planned both for stakeholders and for gatekeepers. So many a times we see that the vaccine rumors, anti-vaxxers, vaccine gatekeepers are being discussed, but there are very few interventions being planned to integrate them to the system or to convert them as from anti-vaxxers to vaccine positivists. This was one of the greatest things, or the most unique and great things which I observed, that intervention with gatekeepers was there. And the quantitative research, which was 2008-9 and 2014 data analysis, revealed that vaccination rates had increased in 2014. A reason of that could be the policy. As I mentioned to you, that tetanus-related rumors were very high during that time. So I would say, but strong funding and very high funding, sustainable funding was there. So what we bring out in the paper was, while causal attribution to vaccine policy itself could not be attributed, the findings said that the broader hypothesis that a gender responsive vaccine policy and programming generally influences both the vaccination outreach and women's vaccination decision. So which means the vaccine confidence for herself and her children. So those things came out from the study. I'm just moving from this side because I think we have Q&A later. And in the benefit of time, what I would do is I would straight away go to the next study. So take a deep breath. This is a completely different study. And this talks about decision makers, conceptualization, and fostering of community engagement for improved adoption and uptake of existing and emerging vaccines in India. So from Kenya, straight go east, and we travel to India. This was, again, a very interesting study because one, of course, it was my PhD study. So to me, it is my baby. Second, as much as I worked in the sector, I did realize that we are very differently dealing with the supply side and the demand side of vaccines. I was very inquisitive to even understand that what do decision makers think about community? How do they even define it? What does they out there in the community that theorization, that otherization actually means? So this study was done in 2017-18, published in 2020 and 2021 respectively. These are the two papers in PLOS One and in International Journal for Equity in Health, a completely qualitative study which was done. It was, and as I said, or as literature says, vaccine decision makers or people in position of power or influence or decision making are generally, in terms of research, known as elites. So I essentially conducted 25 elite interviews of vaccine decision makers in the country. These are national level decision makers, and as many of you might know, India is highly populated, having the largest cohort of vaccine eligible children, which is 27 million annually, 27 million children. So that makes it the biggest vaccine eligible country with the biggest cohort of vaccine eligible population because of its population. Most of these people are responsible both in the country and Southeast Asia region, constituting of people from the donor agencies, UN agencies, and some of the big international NGOs who are responsible for vaccine deployment in the local states. Second was scoping review was done for 24 vaccine policy documents. By policy documents, I mean guidelines, FAQs, which were published by Ministry of Health and Family Welfare, UNICEF, and similar groups, the WHO. And finally, I had a member check-in meeting wherein I shared my study findings, and the first 25 vaccine decision makers whom I mentioned basically acknowledged, not just said that the study findings, they resonated with the study findings. We came up with an operational definition of community engagement for vaccination in the country, so which I would come to it later. When time permits, you can look into the right side diagram. It basically talks about how sequential the process was. Some of it was very concurrently being done. While I was talking to people, I was also identifying these documents, but then interviews were done, scoping review was done, finally the member check-in meetings. That was the sequence of how it was. It took me a couple of months, good nice 6 months, I would say, to complete the whole process. This is Gates Foundation office, the picture which you see in India, and they had kindly hosted the member check-in meeting, which was there. And talking about the elite interviews, some of the key topics, I won't get into the details, it was like, what is the perception, or how does a decision maker, vaccine decision maker, conceptualize community and community engagement? What has been the evolution of community engagement of vaccination from 2010 to 2020? What have been the partnerships? What are some of the examples? And what are some of the barriers and facilitators of implementing community engagement? I won't get into the notes of it, but you can go through it, but because these are the 7 things were the primary agenda or primary research questions. What we came up was some of the key findings, if I may share. Key populations or communities were parents of vaccine eligible children, children who are being vaccinated, populations who are participating in clinical trials. People did mention that gatekeepers were vaccine-resistant populations, husbands and mothers-in-laws, mostly who in the minority communities who resisted vaccination, and anti-vaccine lobbyists. There was a very, if I may add, so there was a very negative sentiment around gatekeepers, and some of the speakers did mention that they did not have any intervention with the gatekeepers. Again, going back to the Kenya study, very different than what was happening in Kenya. Local stakeholders were also taken as or considered as communities. And it was in some cases, NGOs felt that they were part of communities, but they didn't know whether government considered them as communities. Activists, again, media, there was a whole bunch of media engagement, but that was more in terms of addressing some of the vaccine communication issues, but not really considering them as or integrating them as communities. So that was, So in terms of evolution, it did come out that there was more of it began more as a donor mandate when community engagement had to be started, but most of these organizations actually didn't know the nuts and bolts of community engagement, how to go about it, what to do with it, what actually it means, what are the indicators to it. But now they have a better understanding of it. Now every organization does it, but there is still a lacune in documenting the whole process. It is done more as a part of communication than engagement. So that came out very, very aptly. If we tried to rate it, we didn't do it as a ladder in terms of good and bad, but we tried to have certain different categories of it. And there were examples from imposing of vaccination. So you would see the quote out there that we had to hire a muscle man to convince the resistant communities during the Japanese encephalitis vaccine introduction. So while there were examples of this, there were even examples where community were taking the leadership. So every decision maker kind of thought that communities taking leadership is the ultimate aim of their community engagement. Howsoever, much of it was done very intuitively, or much of it was done as communication rather than engagement. In terms of understanding the barriers and enablers of community engagement, I would, just for the sake of time, I won't get into the nuances of it, but some of the bigger things was community engagement per se did not have a policy document. So there was no roadmap of how to go about it, as I have also mentioned, but there was a very strong political will to it. There was intuitive support for it, and there was, again, some funding in the garb of communication being done for community engagement. If you would see the barriers and enablers of community engagement, I have tried to do it in the socio-ecological model. So there is policy level, community level, organizational level, interpersonal level, and individual level. At the community level, of course, as I said, big thrust on communication. So communication, preparation of behavior change communication, dissemination of those in different dialects, those were thought as community level supporting factors which enabled community engagement. Vis-a-vis, these materials were often very flat. The class and class-based power dynamics in the country or in the community. Today, we see so much of politicization of vaccines, even in terms of COVID vaccines. Very less of those aspects are mentioned in the communication materials. At the organizational level, there were some formal partnerships, but there were very less monetary support or incentivization, financial incentivization to keep those partnerships sustainable through the years. At the interpersonal level, the mission Indradhanush, which is the government of India's vaccine program now, the logo has been more explanatory now. But some of the FAQ documents, as I mentioned, and maybe all other countries also have it, all other ministries also have it, irrespective of the target population. So all these FAQ documents were more or less similar, and they need to be thought about and done at the subpopulation level. Say for illiterate women, it should be very different than women who are highly educated. Or for example, women from minority communities or women from minority conservative communities or families of conservative communities should be very different than otherwise. So I think those were some of the barriers and enablers which I found in terms of community engagement for vaccination, the most important being that to explain to decision makers, or also while doing the scoping review of these materials, it was very difficult to get the outcome indicator as community engagement. Say, for example, the moment I asked that, how did you do community engagement? The answer would be, yes, children got vaccinated. So the outcome indicator is still not community engagement for vaccination. It is still taken as an intuitively rather than being done in a very scientific way. The operational definition, if I may just read it out or just briefly mention. So there was this operational definition which came from vaccine decision makers, which said that vaccine is an upstream policy, and it empowers the people. It has relational values of positive relationship between vaccine decision makers, science, and people, and it also impacts vaccination uptake. So I think that was a great thing that we came up with. An operational definition would request every organization or every country or community, if we can come with such operational definitions, it helps in defining output indicators for community engagement for vaccination. So that might be a follow-up exercise which we might consider doing. These, I think, I have mentioned. The study limitations, as you all would see, that both these studies did not have a control group. So that was, of course, a limitation. The external validity threat and non-generalizability, because these were country-level studies and without a control group. And so the validity, or I could generalize it at most to the other developing countries, but not to other developing countries. Changes in the overall vaccine resourcing and prevention environment, which would impact vaccination uptake and also our engagement uptake. Like today with the social media, with communities becoming more virtual, I think things are changing. So I think the community engagement models also would change. Community engagement indicators weren't there, which I mentioned, and the study for the tetanus study was limited to the subset of pregnant women, and for the second study on community engagement, it was limited to the subset of vaccine decision makers only. We don't know what other people, what other subsets of population conceptualize or how they conceptualize community engagement in vaccination. Well, in terms of COVID times, I think some of the things which I mentioned remains true, that more of engagement needs to happen. We see a whole bunch of vaccine hesitancy, be it from the trust aspect or how quick the vaccine was there, or even the access and availability of vaccines in different countries. So it always remains a question mark that how do we do community engagement or gender responsive language, which are both very time consuming things, but in the context of outbreaks and pandemics, how do we do them more effectively? How do we institutionalize them? How do we also empower ourselves for more of virtual dialogues with communities, and considering the digital literacy and internet availability in different kinds of communities. And community engagement has to be more empathetic, using aspects of stimulation, appreciation, listening to the communities. So various studies by Hedy Larson on vaccine hesitancy talks about listening to the people before going and vaccinating them. So those aspects needs to be kept in mind. And I think more and more of with COVID, what has happened is vaccine now needs to be positioned as a social norm than an individual decision. So I think communication materials also needs to be revised in that order, where we can see, or where the framing of vaccines happen as a social norm. So that is it all from my side, and thank you very much.
Thank you very much indeed, Dr. Tapati. That was an excellent presentation, which gives us all the nuts, bolts, and all the nuggets that we need to consider when we are developing community engagement strategies, the need to address gender and social norm issues, and to ensure that all our policies and documents are gender responsive. Thank you very much. And we'll have questions for you at the end of Alfred's presentation. So now I'm more than delighted to introduce Dr. Drewali Alfred, Assistant Commissioner Health Services, in charge of vaccines and immunization for the Uganda National Expanded Program on Immunization, Ministry of Health. Dr. Alfred, you're welcome to deliver your presentation. Thank you.
Right. Thank you, Dr. Eve. I want to join you to thank the Dr. Tapati for the very wide experience she has in this field. So I'm going to just ride on that. Perhaps to say, I will not approach my presentation from an academic angle. Mine will be from service delivery perspective, and the things which preoccupy us there are a little different. We sit between science and politics, and these are realities we live with. The academic community or the scientific community generate evidence, and the political leadership, they have aspirations which are aligned with the people's feelings and people's conditions. As managers, ours is to translate science to meet those aspirations of the people whom the politicians are trying to address. So the perspectives are a little different. Number one, I want to thank you for having invited me and given me an honor to make this presentation. Number two, I want to say that my presentation will be limited to COVID-19 vaccination experience in Uganda, and the elements I am picking are from the National Vaccine Deployment Plan. This has been the most exciting exercise for me because this is planning for COVID-19 vaccination was a moving target. We started planning when we did not know which vaccine was going to be used. We didn't know its characteristics. We did not know the dosage, its efficacy. So we were planning against this target when we were blinded. But certain things were very clear that in our mind that if you had to deliver a vaccine of that nature, you had to use the eyes in your head to see what the playing field will be like. So that's and now I've seen the video is playing in our face the way we had anticipated. So for for COVID-19 vaccination, really our overall goal was to achieve the health goal, economic goal, and social goal. The health goal for us was to reduce reduce deaths, reduce severe disease, and protect the health system from collapsing under the weight of patients by ensuring that numbers of admissions are prevented through vaccination. Healthcare workers are vaccinated to be able to work in the potentially infectious environment. Also, to reduce numbers by vaccinating people who are vulnerable. We already knew that age was a vulnerability and comorbidities was another. And there are people who are overexposed because of the occupational occupation they have. So these were people who were targeted to be prioritized. And we knew from the word go that new vaccines against a new disease was going to be inadequate to meet the targets. So the vaccination exercise was going to be protracted with a limited supply of vaccines. So against that background, to achieve the health objective, we had to prioritize that group. Then we moved to other essential services, which must ensure the economy continues progressing. So you would see the transport sector, the banking sector, the revenue, security, and so on. All those who are enforcing public health had to be protected. Now, the last goal will be a social goal, to allow us to live our lives in happy times and sad moments. So this is this really is a hit on what our goals were from the word go. Now, we based our vaccine deployment plan on principles of equity to ensure that we will give the vaccines to people according to their vulnerability and their risk to developing severe disease and risk of death and other occupational exposures which are critical for continuity of other essential services. We also took a stance that we are going to use the existing institutional capacities to deliver the vaccination exercise. That's why the National Immunization Program is the one leading the vaccination pillar of the incidence management team.
Excuse me, Dr. Drewali.
Yes.
Do you intend to change the slides a bit? Excellent.
Yes.
Thank you.
And lastly, this is more of a background because the presentation is really focusing on engagement. So I just wanted to lay the foundation through those. Then the last one was we agreed that the response is going to be a district-led response using the decentralized system. In that way, we can achieve equity. Now, so this is the outline of the presentation. First of all, what were the issues we had anticipated for community engagement? What is the implementation model? What were the communication objectives? And what were the approaches which were being employed? The methods and materials used, and vaccine uptake summary, which is giving us the result of, apparently the result of all the effort of engaging the communities on the vaccination, COVID-19 vaccination. So here we anticipated that as an issue, the initial demand for COVID-19 vaccines was anticipated to overwhelm supply due to constraints in production, capacities, and the global demand for vaccines. And we knew that this would necessitate a phased vaccination in the order of risk profile by the category. So government had targeted 49.6 actually percent of its population to be vaccinated as to be vaccinated. This is from 15 years and above. And out of this age group, those from 50 and above are the ones to be covered in the acute phase of the pandemic. So we also knew that limited knowledge of a new vaccine coupled with misinformation peddled by some committed anti-vaccine movements could result into vaccination hesitancy. And that would impact on our coverage, on completion rates amongst the high-risk groups. So in line with that, we also knew vaccines are very effective if you complete the recommended doses to achieve the protection that is required, and also population immunity if as is the case. Therefore, community structures are important to ensure access and uptake of COVID-19 vaccines. So from the word go, the focus for us to succeed is to focus on the ground, that using community structures. I just want for engagement. COVID-19 vaccine technologies also is an issue because these are deployed in a short interval between manufacture and actual use. So there is no post-market experience. And these vaccines could easily, because of the numbers of people who are covered during a pandemic, we knew that rare adverse events could have easily been identified. And adequate preparations were therefore put in place to detect, to manage, to report, and document all EFIs, including community reporting. So what was the model we used for the vaccination activity? I will end with the communication, but we agreed that the activity was going to adopt two models, fixed and outreach models. Now, the teams we require, if it is fixed, then the people who know the vaccination importance will passively come by themselves. But where we are moving to an underserved area, we agreed that a district should have 10 teams to manage the outreach and fixed positions, and each team would have one health worker, 2 data personnel, and 1 healthcare worker to manage serious side effects, including health education on the vaccines at that side. And consenting was one of those critical elements. So this is on the supply side, but to prepare the communities to be ready and come for the vaccination itself. 10 members from that community around that site were prepared to mobilize for that activity. Just imagine if there are 10 as a minimum, for argument's sake. If they bring 10 people, you will at least have 100 people vaccinated at a site. So in this case, you can vaccinate 1,000 people per day as a minimum. Now, a district team to ensure that this design plan succeeds is also put in place. So what was our communication objective? Number one was to provide correct, transparent, consistent, and timely information on COVID-19 vaccines and deployment process. This we have done very well. Equip key audiences with knowledge and skills to demand and utilize the COVID-19 vaccine. Number three, to create a supportive policy and leadership environment for uptake of COVID-19 vaccines. Because we also know, because we're a decentralized country, leaders are of different levels of exposure, and if they are not involved and they are not convinced about an approach, then the technical teams will be working against the local political leadership. So we anticipate that we had to bring them on board. So the communication informed the public on the new vaccine. We have seen progressively hesitancy reducing through studies and created eagerness amongst the public. As of now, we delivered vaccines last week. Today, most of the vaccination points are giving me calls that they need more vaccines. So the demand is now there. So what were the approaches we used? We took advantage of mass media and social media, and because a lot of misinformation was coming from there, and we had to go head on. So TVs, radios, and IC materials, as detailed, were used, and social mobilization using district leadership, religious leaders, cultural leaders, and political leaders was also used. Initially, there was a lot of resistance. Besides using the communication or other engagement approaches, we had to, in every district, the leadership were the first to be vaccinated as a show. Although the first priority was healthcare workers, the district teams had to be vaccinated. The religious institutions, all of them were vaccinated. The national heads, including the president, they were all vaccinated under camera. And as I speak, messages of mobilization of people are continuously being run and spoken out by the political leaders. So there are details there. The local councils and village health teams, these are members in the village. They are the ones who mobilize people and communicate the program and the demand which we are now seeing. Healthcare workers, initially we took it lightly. We thought healthcare workers were following the trends. But we saw actually the hesitancy amongst the healthcare workers was failing the program. They were given priority. They were also not vaccinating themselves on time. So we have played both the CMEs to ensure arm them better and advocacy through different channels. We have gotten partners who have taken to study vaccine hesitancy. I can report the highest levels of hesitancy were in Kampala and Mbarara. At the time the initial baseline was done, the hesitancy levels were over 60%. But 2 months ago, a repeat was done. It had reduced to 30. But as I speak now, from what is going on, if that figure must have reduced to below 20%, so it requires another study. So our messages were targeted. There are those which are targeting the general public. There are those which are targeting health workers, those targeting people above 50 years, and those with the comorbidities. Also to ensure, now these are national level issues, but as I had said, more engagement, and those materials are passed over to districts, and district task forces pass it over to sub-county task forces, and there's more activity at the community level than at the national level. So we also have a call center. This number is free, and this is another platform where issues come. So you can see progressively the numbers, people have been picking interest. People from March, when we started vaccinating, 2,000 calls were made. But you can see progressively it has been climbing up. So far, 17,000 calls have been made over the last. So this does not only take COVID messages. If you can see there are 594 which are specific to COVID-19 vaccines. And here, and 82 districts were where those calls came from. And we can see where these calls are coming from, more concentrated in Kampala, where the capital is, and Wakiso, which is the surrounding district. And that is how the distribution is as we monitor it from here. What are the things they are asking? People are asking questions on, I want my second jab, where do I go? I was vaccinated in another place. Should I go to another place or somewhere? Can my vaccination card be verified? If you take AstraZeneca as first dose, can you change to a different type of vaccine? Unfortunately, that type is not there. Can our vaccination cards be verified in the system? Because our system generates an electronic certificate, which is a little difficult with the codes, so it is difficult to forge. I am positive for COVID after taking the first dose. When should I go for the second dose? I want an ambulance to take. Can one be infected with COVID-19 after full vaccination? So you can see these are questions which are coming from the community, and it informs our engagement with communities. On the radio, on TV, more questions of this nature come. So far, we have received a total of 1.4 million doses, and these doses were given out. Now, cumulatively, 82% of these doses have been used, and how has it been used? So we have used 77% of these as first doses, 23 as second doses. You can see that those who are fully vaccinated is just 1.2%. Very exhausting work. And those who have vaccinated, taken first dose, 4.1%. So this slide is showing whether we are on target. Yes, we wanted to vaccinate healthcare workers, and we're happy with the numbers who have gotten first dose. Security forces were in our priority. Teachers were in our priority. The elderly were in our priority, and people with comorbidities were in our priority. There were other groups who kept being included by nature of the work they do. So progressively, you can see that the number of this group is the number. These are people whom we want to vaccinate in order to achieve the medical objective. And if you see then the progress we have made so far, we are halfway. The fully vaccinated, halfway. When you look at those who have ever been vaccinated, those who are fully vaccinated, you can see the proportions are very, it's only health workers who are leading, followed by security. So our issue, what is holding our performance, is not people's attitude. What is holding our performance now is vaccine availability. Of course, there are always outliers. If you can get 70 to 80% of the people willing to take the vaccines, then you give time for and continue working on the laggers. And this is just representing the same. In terms of age, are we on track achieving our objective? I think the numbers tell us, in terms of using the vaccines which are available, the vulnerability by age is where we are putting most of our vaccines. And this lower age is because of the workforce. But you can see 50 years above in Uganda is 3.3 million people. So we have so far reached 9.3% of them. So the immunization space is a crowded space. We work with partners. We have the National Coordination Committee, where we break into different subcommittees on service delivery, logistics, information systems, in coordination, leadership, governance. So those committees, and also legal and regulation committee, those pillars bring their work to the coordination committee. Consensus is built, and we feed it into the mainstream Ministry of Health systems for working. So far, this is what I have for you, just to say the way we have consistently engaged with the communities has given us the leverage to deliver the vaccines in real time. Thank you very much.
Thank you very much, Alfred. That was an excellent presentation, and I'm delighted to hear that the hesitancy has gone down, and now we are only battling availability of the vaccines. I'm now opening up the floor for questions to our panelists. Probably I'll give myself the first opportunity to pose the first question to Alfred. How are you addressing the issue of gender sensitivity and gender equity?
So should I go straight on that, or I take a number of them?
You could go straight on that as we compile additional questions from members. Right.
The way we designed the vaccine deployment plan is using the lens that vaccination activity is a local activity. And if you move from the national level, you give the power to make the vaccination decisions to the local communities at the local government level. And the mobilizers are people who are that community. At this stage, the selection criterion is based on age. It doesn't matter whether maybe you are a woman, or whether you are a man, whether you are living with disability, or whether you have, as long as you fit that criterion, you are vaccinated. If you are living with the comorbidities and the vaccination activity is presented to you, and that vulnerability, not to put you to disadvantage, once you fit in that criterion, it is only in, say, in Cancer Institute where we're a little more deliberate, because this is a center where people are many are on palliative care, and we know they are on medicines which could reduce the immunity. We targeted these ones in very specific terms. So the focus for us is everyone should be reached by ensuring that immunization activity is done close to them, and the local dynamics are what increases the access. Now, for the frontline health workers, that's a different ball game, because equity for us is a principle, and to ensure that people get services according to their needs. So the gender sensitivities and equity, I hope in this generic approach we're able to address them at the local level. And so far,
thank you very much.
Yeah, so far in our feedbacks, we have not gotten a feedback in to the fact that one group has been marginalized. And I've also seen groups of people, special groups of people who have organized themselves, and then they say, the program manager, we are hearing about this vaccine. we want you to come and educate us. And people, I will not go into the vulnerability types here, but there are people who by group identify themselves and say, we are suffering this disadvantage, send us people, or you come and engage us. And we have done this with a number of groups throughout our vaccine deployment period.
Thank you very much, Dr. Alfred. And I have a question for you, Dr. Tapati. It's around the issue of gender and power. If women are say not economically empowered and they have to rely on their partners to get, say, money for transport to go for vaccination and even the permission to go, or even to get somebody to keep the children while they go to line up and get vaccinated. How are African countries likely to navigate around this complexity to ensure that women are not left out?
Right. Before I answer it, could the sharing scheme be stopped so that we could see everybody? That helps just for me to connect with all of you.
Yes,
so
Dr. Alfred, please stop the screen share.
Oh, sorry. Thank you.
Excellent.
Thank you. So I think a wonderful question which you asked, and that is where I would request people like Dr. Alfred, people like that, as we deliver vaccines and vaccinations, how much of the socio-cultural fabric are we considering in terms of even, so there is no direct answer to this, number one. Number two is, the more it is, but the good part of it is, as much if it is integrated by the government. So if the government is always telling in the communication that children needs to be brought for vaccination or women needs to come up, there would be lesser of studies show that there are lesser of resistance. So there were studies done on domestic or intimate partner violence, especially in India. And it was seen that when women stepped out, husbands got suspicious that they are going out for some other purpose rather than vaccination. So now when the government or from different vaccination programs, the communication is done in this way that women need to come, or because maternal decisions or maternal involvement in vaccinating the children is much higher than, these are studies which are there. So very pertinent question. My two-part answer would be, at one level, if there is communication which is done in that way, that makes it much more justifiable. And we did see lessening of violence on women or on female intimate partners when the wife said, or when the woman said that I am taking the child for vaccination. So first, at a high end level. Second, I think in all the meetings, the village health team meetings or other meetings which are happening, these sensitization also needs to happen along with sensitization on vaccines and vaccine dosages. As of now, we have limited vaccine communication has limited itself to around dosages of vaccines, where you get the vaccines, and certain miscommunication around vaccines. But many of these, the roots of many of these miscommunication, misinformations or rumors are also very embedded in the socio-behavioral or socio-cultural fabric of the country or the community. So in those discussions also, the element of gender needs to come up, I think needs to be integrated more strongly than ever before. And third, if incentivization is done, and I know different countries might have different models of incentivization, if incentivization at times do work. So very, very small, little, not really monetary incentivization, but maybe something like certifying, giving certificates for being the best village where everybody, or being the best community where everybody is vaccinated. So those things can be done. Or a congratulation message via WhatsApp, which is very cost effective. So some of those incentivization, which really doesn't involve monetary resource, can be utilized to congratulate women for vaccinating her child. So that would be nice, or that would be a big boost. But I'm sure it has to happen at all the levels. It has to happen at a household level. It has to happen at the village health team meeting level, so which is at the community level, and it has to happen at the policy level also, incorporating or integrating that language in the vaccine communication. So, Dr. Eve, hopefully that answered your question.
Thank you very much, Dr. Tapati. I have a question for you, Dr. Alfred. Miss Rose McKenna is asking, can she receive the COVID-19 vaccine if she's unwell? Dr. Alfred Drewali?
Is vaccination in the first place is good for when you're in good health. If you are unwell, is it an acute problem or it is a chronic problem? If it's an acute problem, I think the best is for you to seek care and get attention for that problem so that you do not have confounders. But if it is a chronic issue, chronic conditions actually put you at risk. So cancer, high blood pressure, heart disease, liver disease. So these put you at risk, and it is better you get vaccinated unless there is an absolute contraindication to the vaccines. And most of the contraindications to the COVID-19 vaccines are actually related to previous history of maybe is anaphylaxis. The absolute contraindication is I see is anaphylaxis. So you will only know that you're anaphylactic if you have ever got it. So most likely the first dose you will get it, then a conclusion not to give you will be in the second dose. So I think I would answer it in that context.
Thank you very much. And we have another question here from Leslie. Is there a concern? This is for you, Dr. Alfred. Is there a concern that as you work on the vaccine availability problem, people may lose interest or even confidence in taking the vaccine over time?
Now, last week I was engaging with healthcare workers in a region, and somebody asked me that question, and that what should we do with healthcare workers who do not want to get vaccinated? And on a lighter note, I said, okay, they will be mobilized by death. Now, this is serious because the issue of we are dealing with a pandemic. The issue of whether you get vaccinated or not is not really a matter of choice. And a person who is on that course needs help because it means the risk appreciation is limited. Because by the time you come to know that you need a vaccine, it may be actually too late. So the issue of people losing interest actually is not there. Actually, what I have seen is people becoming violent to healthcare workers because they have come when the vaccines are over. So and when countries go through waves, the politics around COVID-19 starts to disappear because you see the numbers of people dying, people whom you know are dying, and people who were given opportunity to vaccinate and they were still academic about it, they are hit by the disease. Conversions from such people are actually driving. So in Kampala, you do not need now time to give a lecture to people that vaccines, you go for vaccines. Actually, people need vaccines now. So I think the real message is that the issue of vaccine availability is a big one, and it is a global issue. And Africa is disproportionately being disadvantaged. Even when you have money in your pocket, you cannot get it as and when you wish to get it. So when you are prioritized for a risk. And if you don't seize that opportunity, I think you are trading on a very shaky ground unless you get your facts right.
Thank you very much, Dr. Alfred. And there is another question for Dr. Tapati. How can community engagement structures continue to help if, say, a country is experiencing a challenge where availability is a problem and potentially the community loses interest or confidence in taking the vaccine over time?
So your question is how community engagement can be done effectively?
Yes, how the community can help to keep the public interested as we battle the shortage of vaccines. You line up, show up day one, no vaccines. You line up, show up day 3, no vaccines. Probably if you try that 3 or 4 times, you may lose interest.
Absolutely, absolutely. So I think you already answered the question, and what Dr. Alfred was also mentioning, that this is, and through my study of work, what I saw was, one, there is no magic answer or magic pill to it. It is a long drawn process, and you have to have built the trust with the community such that, and as we have seen, that the 3 A's, acceptability of vaccines, availability of vaccines, and the vaccines are affordable. So all the 3 A's have to be there. First, they should be scientifically, evidence should be shared in a layman's language so that people accept it. Second, yes, we have seen that in HIV, we are seeing it in COVID. It is not because that people have come, then they have to return back homes. They have lost their day's wages. They are upset. They are angry. They are tired. They have lost the money. So, and all those feelings have a ripple effect in the next run of not just getting vaccinated, but also in getting, we have seen it in the clinical trials for vaccines. Even for COVID-19 vaccines, getting a few thousand volunteers was getting so very difficult. We have seen it not just in COVID, again, back in the time for microbicides also, we saw recruiting women was so difficult. So I think how policymakers, decision makers, science per se is being communicated to people in a trustworthy way is very important. It's a great time I think for COVID, that we need to take a lesson that vaccine politicization will not help at all in any country. So the equity-based approach, which is happening in Uganda today, which is happening in most of the countries today, I think realizing that is one of the biggest ways to keep that trust level up there. So if I can give you an analogy, between a mother and a child, think that a mother is telling that I could not cook today. The child will be upset, but the child will not lose trust on the mother. The child will come back again to say that I'm hungry. Have you finished cooking now? So take that analogy between a government or between a system and the community. If that kind of a relationship, trustworthy relationship can be built, the same things of access, that people are not getting vaccine, people will understand why the vaccine is not there and by what time it would be there. But unfortunately, we invest very less in terms of relationship building. Unfortunately, in public health, in social science, in humanities, we do very less as compared to corporates, or as compared to, somebody gave me the example that if for selling a toothpaste, maybe much more customer relationship is built than for selling or than for the uptake of vaccines. So I think we need to, as governments, we need to invest much more in terms of the relationship building as much as it is done in business. Once that trust is built, the three aspects of acceptability of vaccines, affordable vaccines, and available vaccines are the three, I think, important pillars in terms of dealing with the elements of community uproar when vaccines are not available, or complacency, which we are seeing right now of what would happen anyhow. So all those things, all those things gets, I think, I won't say it is easy, but I would say that it is, of course, complicated, very socio-culturally dependent, and needs a whole bunch of investment rather than just an intuitive thinking that, yes, it has to be done. So, yeah, hopefully I answered your question.
Thank you very much, Dr. Tapati. I have two questions for you, Dr. Driwali. One is, how are you handling the issue of the vaccine not being compulsory, yet scientific evidence for not vaccinating other groups is not generally available, except for the pregnant and lactating women? That's question one. And then question two is, initially people with allergies were exempted from the vaccination. Has this changed, or they are still among the exempted group?
Okay. Thank you, Eve, and participants who are raising those important questions. In Uganda, vaccination through routine immunization is compulsory by law, and parents and school teachers which do not enforce that are liable for punishment. And these are vaccines which are registered by WHO. There is a lot of information on them, and there is confidence about their safety profile. But the COVID-19 vaccines we are using, yes, the clinical picture efficacy is clear, but there are the information on possible side effects. Nobody is pretending that they are all known. So they are registered under emergency use listing, so that we continue to study the safety profile through the pharmacovigilance platform. So for that reason, it will not be fair to make it compulsory when you still have room for other unknown effects of the vaccine. Also, the second aspect to that is, you cannot make what is very rare compulsory, because when you make a law, and we were guided, we wanted to make it compulsory, but we are also guided by the legal, the Solicitor General. We are guided that when you make it compulsory, you must provide it. So you cannot make what you cannot provide compulsory as a government. So those are the two aspects to not making it compulsory. The issue of contraindications. Outright contraindication is when you have reacted to the first dose. But if you are having allergy or you are asthmatic, it is also an indication. It increases your risk of severe disease. So you will take it for that reason, but it depends on what allergy you suffer, not indiscriminate allergies. Yes, I think I've talked. So absolute contraindication I've seen for most of the vaccines is when you have an anaphylactic reaction. But if you have urticaria as an allergy, then the best you do is to have it managed, detected and managed. Yes, that's where I would stop.
Okay, thank you very much. And we have a question for Dr. Tapati.
Yeah.
Somebody would like to know from you whether you found gender preferences at the time of vaccine shortage.
No.
No.
Yeah, so my direct answer would be no, but depends on the kind of vaccine. So especially for HPV vaccine, the cervical cancer preventing HPV vaccine, we have seen a very strong feminization of the vaccines. Many countries pose it as if it is a vaccine only for women, vis-a-vis, and that is absolutely from finance and planning standpoint, vis-a-vis the US, where HPV vaccines are given both to adolescent girls and boys. So I think, yeah, HPV could be one of the examples where feminization or a very women-centric approach has happened. But I think, again, it is a reason for resource-limited settings like Africa, or African countries, or several Asian countries where it has been done. But apart from that, I haven't seen a vaccine which is meant for both a male kid and a female girl and a boy, and where that kind of a behavior is there. That said, as I mentioned long back, the Gates Foundation and WHO funded study on, I did see household level preferences by parents being done for vaccinating the boys more than the girls. So that was there. Some of the qualitative study results did show that, though quantitative. So vaccine preference, because of the gender of the child, one was seen in terms of at the household level. Second, many vaccine hesitancy studies in conservative country settings show that when the vaccinator is a male vaccinator, parents are generally hesitant to get their female children vaccinated. So that is another gender aspect of the study. Third thing, which Dr. Eve, which you mentioned initially, some of the household, there were resistance that the mothers take the kid out for the vaccination, and that was again another gender nuance to vaccination. But overall, I would not say that at a health workers level or a vaccinators level, a gender discrimination has been done. It is more of a household and a community level thing, which studies have shown.
Dr. Eve,
thank you very much.
Dr. Eve, what Dr. Tapati is articulating is at times a positive discrimination. Some people do not give vaccines to their girls in order to protect them. Their intention is to protect them, but inadvertently exposing them to the risk of not being vaccinated. So that social dynamic needs to be understood. Their intention is not to hurt them. The intention is to protect them. But beware of an ignorant person. When he wants to help you, he can hurt you.
Right. And I think, yes, I'll add to Dr. Alfred that most of the vaccines unfortunately had the rumor in many countries that this vaccine would sterilize my daughter. And that is the reason where tetanus vaccine got affected, where HPV vaccine girls were not vaccinated. And in COVID also we see that. I was speaking with an adolescent the other day, and he was telling me that I won't get vaccinated because God alone knows in 5 years' time it might show that all who have been vaccinated have certain disease. So these rumors are like not just spreading, they are actually having their seeds in the minds and hearts of so many people that they have to be actually uprooted. So one of the I think gender discrimination, what we see in vaccination, its roots lies in the vaccine rumors and vaccine misinformation.
Yes, thank you very much. I'll just have a couple of questions for Alfred, and then we can continue the conversation outside the webinar. The first question to you is, can one be given the vaccine of choice in public facilities? And the other question is, how is communication done on the side effects of the vaccines or the rumors around the COVID-19 vaccines?
Okay. Now, we have a whole department in the Ministry of Health whose work is to communicate to people on a health issue. And that picture, that call center is part of that department. You receive the information and you listen to what are the concerns, and then you engage the community on that topic by providing alternative understanding, explaining what explaining the kind of things which are claimed, that you get a magnet which gets stuck at the site of the vaccination. You get a bulb which lights out. And if you see the psyche of people who manufacture the misinformation, there are indeed things which touch on beauty, they touch on reproductive life, they touch on yes, impotence and things like that. So it's scaring, and by using those tenets, you demobilize the target groups. So you need to listen to what are the issues and how does the community respond to it, and how do you then provide the information with the literature which exists somewhere else, and also using basic understanding of the science of the vaccine. So you have to repackage your message and continuously keep providing the information to them. At times when some rumors come and you leave it, they die. We have also seen some members of the media, they keep propping and irrigating, they keep watering certain messages. So you find it is the elite. Some of the messages are not actually reaching the real communities. The social media community is talking to themselves. We had a measles rubella campaign in 2019. If you were in Kampala and you listened to the social media, you would just conclude that this activity has failed. But our statistics were telling us to the contrary, because we targeted to vaccinate 18.2 million people, but we vaccinated 19.4 million people. So so this is what I've come to see. If you are in the capital where the digital natives live, they can sway you off your strategy. So engage also younger groups to deal with that, because we have Ministry of ICT, which has got a number of people who manage the social media handles. So they ask the questions to me, for example, I move with my team. They ask the questions which are in the social media space. We respond to them, and they are also tweeting on behalf of government. So the Ministry of Health social media handles are also running the same. So you have to provide that rebuttal for the group who use that social media. And that's how we have been doing it. And by being consistent, you now provide your face to the media as a signature. I think some of us, when we now have no privacy, when I move anywhere in this country where they will say, "Oh, I know you, I have seen you, but where did you see me?" They saw me on TV. So you have to provide credible faces to give information to the country consistently. The other question was around the choice. Ladies and gentlemen, at this moment, the room for choice is limited. You can see we want to vaccinate 22 million people. I flashed here the total number of doses we have received in more than 6 months is 1.4. So I do not see where the room for choice is. But those who want to exercise that choice, as I said earlier, are taking a very risky path. Now that other countries are contemplating third doses to be given to their own citizens, the poorer countries will wait longer to get their first jab. So these realities so if our circumstances do not give us that luxury, you are better off having the partial protection when the opportunity comes. Actually, we were asked by the president which is the best vaccine. I was very surprised when the chair of the Vaccine Advisory Committee gave him the answer that the best vaccine is the one which you have access to. So choice has no room in this thing.
Okay.
Right, thank you. Thank you.
That is an interesting and important caution. So we are closing with a remark from a colleague who says that based on their experience in the development sector and working with the tribal communities tend to give up either because of mistrust and then the non-availability of vaccines, and then the opportunity cost of having to leave their jobs. They go and line up to get vaccines and potentially they do not get vaccinated. That I think this is a challenge that African governments must confront and address. Mr. Commissioner, what is your thought on that?
Just recap it again.
We have a colleague who has spent over 20 years working in the development sector, and particularly with tribal communities. And they have found that during the pandemic situation, there are concerns around lack of trust in the vaccine and also non-availability of vaccines, and the fact that people forego their working times, they go and line up to wait to get vaccinated, and at times they don't get vaccinated in some, and that this is a potential as part of our COVID-19 response strategy.
So you can see that is a typical situation which requires counseling. You know, when I move to engage with the communities, one of the things we are very open about is the difficulty with which we are trying to get vaccines. And an average person should have an understanding of the dynamics. And now I'm beginning to see political leaders disagreeing on in debates, political debates amongst themselves. And say, no, government is not getting vaccines. Then, okay, show us where the vaccines are, we'll go and get it. So I get that kind, now they take the debate. It means there is a significant group of people who now understand the reality, and they are able to, the communities are able to fight the misalignment and the political issues around vaccines themselves. So the communities need to be told that because anger comes out of the perception that someone is playing games on you. That's where the anger comes. But if the message is clear that you are missing because everybody is missing, and everybody is missing because the vaccines are actually not available, and the little which come, when you are allocating it, you are very clear, you are transparent. You say, we are allocating based on population. We are giving it to every district in the country. The priority is this group. So people get to understand that. And then we say, you wait for your time if you are not in that category yet, but continue using SOPs to keep safe. And these SOPs, we are going to use them for a longer time. Let's not make shortcuts about a very serious thing. And this message is coming from the president, it is coming from the minister, it is coming from technical officers, from district leaders. So and the consistency with which we communicate, it also gives confidence so that people live positively. We have lived positively with many things before. So you can also live positively with the bad news, as long as you know that you are not being cheated. And that's the only weapon we have. So then they will take the frustration in a positive way. They will understand the non-vaccination status in a positive way. And as Dr. Tapati had said, the issue of trust is critical in this kind of work, because people whom we are vaccinating ideally are not sick. So they have the opportunity to ask many questions. But when they are sick, actually, they don't ask questions. I always ask, do you negotiate your bill in a clinic? No. You go to a clinic, the doctor names you a disease, he prescribes for you, he gives you a bill, you pay. Do you negotiate? The standard practice is you don't negotiate, because the healthcare is powerful and you are desperate because you are sick. Vaccines, people are not sick, so they can ask and they can opt out, but you need to give them reason for them. You quantify the risk they run by that behavior and the benefit of being vaccinated, and that's the only tool we use. Thank you very much, Dr. Eve.
I think this has been an excellent webinar, very well balanced from the two experts. And I want to extend a vote of thanks from the African Palliative Care Association to you, our panelists, Dr. Tapati and Dr. Alfred. And I want to thank everybody who has taken off some time to attend this webinar. Thank you very much indeed. We should all go out there and get our 2 or 3 doses of the vaccine. And I wish you a wonderful afternoon, evening, day, or night. Thank you very much. And we look forward to catching up next month.
Thank you.
Thank you.
Thank you.
Before you sign out, thank you very much once again for giving this wonderful, wonderful opportunity. It was so nice to meet people I have known, APCA colleagues for some years now. But Dr. Alfred, this was the first time I met you, and this was such a live understanding of what is happening in Uganda. Part of my heart, of course, lies in Uganda because I began as a student. I did my internship out there. I did meet some of your colleagues at the Uganda AIDS Commission. So and so it was extremely nice. And I think people are, from the questions, it was so very apparent that people are concerned, seriously concerned across the globe. And I was so happy to see people from different continents participating in it and having those very serious questions around implementation, around vaccine hesitancy, which also means that we are in it together. It is no more just a policymaker's worry or headache or concern, but a person working in a small village, tribal village out there is also concerned on similar issues. So I think that is a huge leveler. That is a huge leveler, something very different than maybe which we saw in other diseases, especially HIV and other things, where stigma was very high. Fortunately, here stigma doesn't play a role because it is very generalized. As Dr. Alfred was mentioning, you are like some people who are in positions of power, who have money, who are rich. Everybody is in equal amount of risk. So yeah, I think that in itself is a great leveler, which should actually help us in building the social solidarity, global solidarity we are looking for vaccination uptake. Thank you.
Thank you very much indeed.
Thank you. Thank you so much.
All right.
And
Thank you.
I would look
Bye.
forward to the link for the presentation recording. And yeah, thank you so much. Yeah, and Dr. Alfred would be very benefited if you can share your contact details, or I can take them from APCA. Yeah,
please.
Yeah, thank you.
All right. Thank you.
Bye-bye.
Bye. Bye.
Thank you. Bye.
Bye. Bye.
Mm-hmm.